Okay, so POI, early menopause, a quick tour in 15 minutes. Okay, when you're ready, Fiona, next slide, please. Okay, so again, stages towards menopausal transition, what the journey involves, and we've already gone through this in the morning. That's the premenopause, when none of the changes have happened, the symptoms or menstrual cycles or hormones. Then comes the perimenopause, when the symptoms start appearing as well as the menstrual cycles change, and there will be hormone fluctuations. The FSH, LH, estrogen will start fluctuating up and down. That culminates in menopause. This is when periods stop completely for at least a year. That's when we technically say menopause has happened. And any phase from that point on till the end of life is postmenopause, which is until maybe 20, 30, 40 years of a woman's life. The key bit in this slide is that the symptoms can happen in perimenopause. So even though a woman may be experiencing periods, having some menstrual activity, the traditional thought was that we shouldn't be offering HRT because estrogen is still around. That is not true. We should be offering HRT or non-HRT intervention if the woman is having significant symptoms, even though she may be having her periods, because there'll be in the month or the cycle when the estrogen levels will be quite low. Next slide, please. Timing of menopause. We know the timing varies based on so many factors, genetic factors, environmental factors. But it's key to know that about 10% of women will have an early menopause between 40 to 45, and 1 to 2% of women will have premature menopause below the age of 40. It's never too early. You can have women even soon after puberty or before they go through puberty who may be diagnosed with premature menopause. So in a young woman with symptoms typical of menopause and having stopped periods, this diagnosis should never be dismissed. Of course, remember again, ethnic differences can play a part. Southeastern Asian women, for example, had menopause 5 years earlier. That's natural age of menopause is about 46 on an average as compared to 51 for Caucasian population. Similarly, some of the case reports suggest the prevalence of POI is more in Asian women or Southeast Asian women, about 2 to 4% instead of 1 to 2%, which we know for Caucasian women. And a lot of environmental genetic factors could play a role in that. Next slide, please. Why do we say it's POI rather than premature menopause? Because that's the name that covers all various causes of ovarian insufficiency. And the terms of premature ovarian failure should not generally be used because the POI covers both natural iatrogenic causes. Next slide, please. Prevalence, we saw 1 in 100 in general, but could be more in certain ethnicities. Next slide, please. It's a diagnosis with significant consequence. One of the things we've noted in the last 10, 15 years is you still get patients, women referred to clinic who have had a delayed diagnosis. They have lost a bit of time in initiating HRT that has had an impact on their bones. They may have had a window of opportunity for their fertility, which they may lose. And therefore, diagnosis has significant consequences. So it should not be missed, should not be delayed. Not only it's the lack of estrogen that causes the short-term symptoms and brings down the quality of life, but also it's the long-term bones, osteoporosis, cardiovascular health, heart disease, and the impact on cognition. Besides loss of fertility, they will all have a major impact on the life course of the woman. And remember also that 20 to 25%, 1 in 4, 1 in 5 women may go on to resume some cycles. They may go on to have some ovarian activity, may have some periods and ovulations, especially if no cause has been found for the POI or they have an immune cause for POI. They will go on to resume some cyclical activity. So never say never and never say that the pregnancy is impossible. Next slide, please. Causes, 80% of women we see with POI will not have an obvious cause. Despite investigations, tests, we will never find the cause. In others, 20%, you'll have genetic, immune, infections like tuberculosis, HIV, mumps, metabolic, galactosemia, toxin-related, or of course, you have iatrogenic early or premature menopause. This could be because of removal of ovaries at surgery, or chemotherapy, radiotherapy, or embolization. Next slide, please. What causes unexplained POI? What is it in those 80% of women with POI that causes the ovaries to stop functioning early? The thought is that all those millions of oocytes which are there at birth, something happens to them. They either don't mature, or they get destroyed too fast, or there is some sort of reduced pool right in the beginning. So the reproductive lifespan, how long do the eggs last in their 40s or 50s, depends on the pool of eggs right at birth and how fast these eggs are utilized. And in simple terms, for women with unexplained POI, it appears that they are either born with a smaller pool because of the destruction of eggs right before birth or around birth and throughout life, or they use up their eggs faster. So instead of lasting the eggs until 40, they finish having their eggs in their 30s or 35. Next slide, please. We're going to not dwell on this. Next slide, please. So genetic causes affect about 10 to 20% of women with POI. They usually have a family history of another member in the family affected by the similar history of early menopause or premature menopause. And most problems will arise from changes to X chromosome or autosomal genetic variations. There are several gene mutations which are being discovered year on year. So in future, we'll hopefully have a big panel of genes we'll be able to test where we can suggest somebody what their risk of POI is. We're not there yet, but something for future. Next slide, please. Turner syndrome, this is the commonest genetic cause for premature menopause, affects about 1 in 2,500 live births. It's the loss of X chromosome, either complete or partial loss. And these women have multiple health issues, not just the one affecting ovaries, but they will have cardiac issues, kidney issues, blood pressure, cholesterol issues. So they really need a multidisciplinary care in specialist Turner syndrome clinics, which are happening throughout the country in some of the tertiary hospitals. Some women have mosaic X pattern, so they may have genetic X changes that may have two cell lines, and therefore they can have some menstrual activity, ovarian activity until their 20s, 30s, or even longer. So it's important that they are seen in the specialist clinics for the best advice. Next slide, please. Now, I'm not going to go through again how we look for the Turner syndrome characteristics and what are the management, because that would be a topic on its own. Next slide, please. But what is important, the message to come across is that, again, women with Turner syndrome may be born with a normal number of follicles at birth, but it appears that they lose these eggs out early. There is an accelerated damage to these eggs. And they have lots of long-term health issues, hearing difficulties, learning difficulties, loss of bone density, celiac disease, thyroid issues, cardiovascular issues, liver function problems, cholesterol problems. And of course, if they do go on to have either a natural pregnancy or they have egg donation pregnancy, then issues related to blood pressure, heart disease are relevant in terms of health of pregnancy and their own health. So again, multidisciplinary care is the way forward. Next slide, please. There's a quick slide about how you can preserve fertility in women with Turner syndrome who have some ovarian activity. So if you do come across a woman who's been diagnosed with Turner syndrome, but would like to preserve fertility, they have some menstrual function because they have a mosaic karyotype, for example, and this would be really one of the options that in modern world can be offered. We did a series of egg freezing for women with Turners who had some ovarian activity, and it does look like they do go on to freeze a good number of eggs despite having low hormone levels. Next slide, please. The other condition which we often talk about in genetic POI is the fragile X syndrome. This is where there's a pre-mutation which affects the X chromosome. And again, what this will mean is there is a higher risk of premature menopause in life. And it's important that if somebody is diagnosed with fragile X, they are sent for genetic counseling, because then they will look at the family tree and it will also inform other members of the family if they have to have a test done and whether they would be at risk of POI. Next slide, please. Next slide, please. Then we look at the immune causes. Now, often women who have POI have associated condition. They may have Hashimoto's thyroiditis, they may have diabetes, they have adrenal conditions, Sjogren's, rheumatoid arthritis or inflammatory arthritis is common. They may have bowel disease or celiac disease, inflammatory bowel conditions. multiple sclerosis, myasthenia. So you see almost up to 30% of women with POI may report some or other immune condition. And in some of these women, certainly immunity plays a role and may be causing the damage to the ovarian follicles. So the test that we often recommend in a woman who is coming first time for the POI clinic is first of all genetic. We look at the karyotype to rule out Turner's. We look at Fragile X screening. But from immune perspective, we will look at 3 antibodies. We do ovarian antibodies, celiac antibodies, and thyroid antibodies, mainly because these 3 are strongly linked with POI. And of course, some of them then need further attention in terms of general health. Next slide, please. So if a woman does have adrenal antibodies, then that's important that they may go on to have adrenal insufficiency in future. And you would want to involve an endocrinologist who would keep an eye on the adrenal function in future life. Next slide, please. Iatrogenic premature menopause is becoming commoner, and partly because there are many surgical options now available to women to reduce their risk of having cancer in future. So surgical menopause as part of iatrogenic premature or early menopause is being increasingly seen. Surgical menopause can be severe because you suddenly remove the ovaries. Within 24 hours, your hormone milieu in the body changes. There is a profound drop in estrogen, testosterone overnight. So these women can have more severe symptoms. They can be more persistent and may need more intervention with higher doses when you start initially with HRT. The damage to ovaries, of course, in terms of chemotherapy or radiotherapy varies with the combination of agents or what sort of radiotherapy dose you use. Alkylating agents, chemotherapy for cancer are the most damaging for ovaries. And risk-reducing surgery for BRCA, BRCA genetic risk for breast cancer and ovarian cancer genes. Risk-reducing surgery by removing both tubes and ovaries is becoming more common. So we're seeing a lot of women post-BRCA risk-reducing surgery come for advice about HRT. Next slide, please. This is a paper that's available on the RCOG website. We put together some guidelines for women who have risk-reducing salpingo-oophorectomy and who want to consider using HRT until at least the age of 50. And whatever evidence we have suggests that if you have risk-reducing salpingo-oophorectomy and a surgical menopause, even with BRCA, you can safely use HRT at least until the age of 50. Beyond 50, currently not recommended. However, we are seeing some women choose to take it. And in future, we'll have more evidence as we now gather more evidence for these women reaching their 60s, whether how safe it is to continue with HRT. That will be interesting to see as we get more data in the next few years. Next slide, please. Infections, toxins, again, these are uncommon causes, and I'm not going to spend a lot of time. Talked about the infections which are linked with POI. Next slide, please. Metabolic condition, galactosemia is one of the commonest. We do have a dedicated clinic at the neurology unit in UCLH where we see women with metabolic premature ovarian insufficiency who again need a multidisciplinary care alongside HRT as part of the POI management. Next slide, please. Now, how do we diagnose POI? So this is really important for somebody working in primary care and then referring patients on to secondary care for further investigations or treatment. So the situation usually in the clinic is lack of periods. Most women will first notice lack of periods for more than 4 months. And we take a 4-month as a cutoff criteria. So if someone has suddenly not had period for more than 4 months, it's not pregnancy, and there's no other explanation, then of course it's going to be something wrong with the hormones that's causing the lack of periods. And if there are especially symptoms of lack of estrogen, such as flushes, night sweats, or mood changes, then it becomes even more important not to miss the diagnosis. So amenorrhea for more than 4 months, and if you do bloods, simple bloods, FSH, LH, estrogen level, those will be the key. And if you see FSH more than 25, more than 2 occasions, that is certainly likely to be POI. Estrogen deficiency symptoms present for many, but may not always be there for everyone. Some women will only be picked up when they present for fertility treatment. And finally, AMH is not a diagnostic marker for POI. It can help to know that this ovarian store is small, but it's something that's not mandatory. Next slide, please. Next slide, please. So specific clinical investigation, what is expected in the primary care? Generally, it will be FSH-LH estrogen. Once the diagnosis is confirmed, many primary care physicians will also check a prolactin and a thyroid level to make sure they've ruled out differential diagnosis. Once the diagnosis is confirmed, if they are referred to a specific POI clinic, which is ideal for multidisciplinary care, then of course we will do a karyotype, a Fragile X, which are the genetic testing, and the 3 antibodies I talked about. Once the patient has been diagnosed, initiated on hormone replacement or some other form of treatment, we'll keep an eye on the general health, and we tend to do annual or every 2-yearly follow-ups. We look at the cholesterol, the diabetic screen, the celiac screen, and a bone density to make sure the bones are healthy. And we do that every 3 to 4 years for patients who are maintaining a good bone density. For Turner syndrome, the additional investigation which is important is heart echo, because there can be risk of aortic dissection that can happen. And of course, baseline bone density, we repeat DEXA considering clinical situation. Next slide, please. Impact on bone health, and I'm not going to again spend a lot of time because my colleagues have explained what impact on bone health does happen with lack of hormone. POI is really key. Early onset lack of estrogen will impact the bone directly, and there are enough comprehensive studies which suggest that lack of estrogen at an early age will cause osteoporosis unless it is treated with hormone replacement, or there is a plan in place of non-hormonal therapies to protect bone. That could include lifestyle or other non-hormonal medication. The gold standard is HRT, and therefore making sure HRT is encouraged until the age of natural menopause, that is the key. The specialist advice when HRT is contraindicated would be to look for non-HRT medication. Next slide, please. If you look at the impact on heart health, again, lack of estrogen will increase cholesterol, LDL cholesterol, dip the HDL cholesterol. It's not good for heart and blood vessels. So therefore, early intervention with hormone replacement therapy is recommended for women with POI or early menopause, at least until the age of 50. Thereafter, it's an individual decision whether to continue or not. Lifestyle is key. While you're giving HRT, making sure the patients have healthy lifestyle, avoid any bone or heart unfriendly lifestyle is key as well. Next slide, please. Cognitive health, dementia, unlike where we don't have a lot of good evidence for women after 50 in relation to dementia, HRT, we are still kind of looking at observational data. There is quite good evidence, although observational, in women under 50 who have POI or early menopause, that lack of estrogen can impact their cognitive health. And starting HRT early would be able to prevent this cognitive decline in later life. Next slide, please. Psychological or psychosexual impact. This is what we are not good at treating as physicians. I still have patients who have had very little psychological or psychosocial impact when they've gone through this journey of diagnosis of POI. These women do remain at a high risk of having psychosexual and psychosocial problems, and therefore offering them psychological support either within the team that's caring for them or giving them access to other help sources is really key to protect their mental health. Next slide, please. Fertility-wise, it's egg donation IVF, which most patients need. Remember, 5 to 10% chance of natural pregnancy remains for those with unexplained POI, and the miscarriage rate doesn't seem to be high with spontaneous conception. However, HRT is not contraceptive. HRT can help with conception because it maintains good estrogen levels and a good endometrial lining. Oocyte donation, egg donation IVF is the obvious treatment if someone does not conceive naturally despite having POI. Other stem cell therapies or PRP injections and other adjuvant treatments are research techniques. They should not be recommended right now because we don't have enough evidence of safety or efficacy of these in POI women. Next slide, please. Now, next slide, please. And of course, the symptoms attributed to lack of estrogen are the typical menopausal symptoms, and I'm not going to repeat them here. Next slide. Next slide, please. Now, addressing symptoms, we looked at the lifestyle modification, the changes at workplace. There are nutritional interventions. Some of these will be talked about my colleague Kate, who is going to follow this presentation. Non-HRT medications, and again, she will talk about a few, mainly the antidepressants, gabapentin, clonidine, and then of course we have HRT, which is the gold standard for women with POI. Next slide, please. Next slide, please. Okay, with non-HRT, the important bit is women who have POI or early menopause because of sort of indications where you can't use HRT. Let's say treatment of breast cancer or hormone-sensitive cancer or multiple thrombosis. In those women, of course, these medications will be really the first line where we can't use HRT. SSRI, SNRI, gabapentin, pregabalin, and clonidine. They do suppress hot flushes, night sweats, and improve mood and sleep. However, they can have side effects, the dry mouth, constipation, sometimes weight gain, lack of libido. So we should use these carefully, especially in women who can't have access to HRT. Next slide, please. HRT, of course, is the gold standard for any woman with early or premature menopause because it does improve long-term health outcomes. And which one do you use? Do you use the combined pill or do you use the hormone replacement with natural hormone? The combined pill versus HRT, there have been very small randomized trials head-to-head. HRT appears to be the winner right now because in the long term, it's much better for the bone and the heart health. However, there is a big trial currently happening in UK, which is called as the POIS trial, that is comparing the two treatments in the long term to see which one might be the winner. Right now, the HRT appears to be better. However, the pill has the advantage of contraception. Next slide, please. HRT recommendations for estrogen. I'm going to skip a lot of this. That's because we have to stick to time, but also because I'll take questions at the end if you have specific questions about HRT for POI. The message is younger women need more HRT, more estrogen dose, and you might have to use the 100 patch or the 4 pumps of gel or 2 to 4 milligrams of oral dose of estrogen. Next slide, please. And for progesterone, it's at least 12 to 14 days of the progesterone cyclically, or it's a continuous combined regime, especially after 5 years of using a cyclical HRT. For women who wish to do egg donation IVF, it might be good to continue cyclical HRT because that might help with endometrial preparation. Next slide, please. Next slide. Vaginal cream specialties can always be used, especially women with breast cancer. And Juliet did a whole round of what is the safety of the vaginal estrogen following breast cancer treatment, but they can be used for most patients. And again, these don't get absorbed, so there are no risks systemically of using vaginal estrogen. Next slide. And HRT risks, it's really key to understand. None of the risks about blood clotting or none of the risks about the stroke and the breast cancer that we talk about in women above 50 or 60 should be extrapolated to women with POI or early menopause. These are young women who have a different set of risk. They do not have an excess risk of breast cancer from HRT, which is simply replacing the hormone. And their blood clotting risks are overall less because they are younger women below the age of 40 or 30. And so therefore, it's important to make sure to let the patient know benefits far outweigh any potential theoretical risk. Next slide, please. How long to take HRT? For most, we will recommend to take it at least until 50. But it's individual decision and they could continue after that as long as benefits outweigh risk. Next slide. So in summary, it's important that we offer psychological support, higher doses of estrogen for younger women, and of course, preoperative plan for those who have surgical menopause so that the discussion happens before they have the operation and there's a plan in place at the end of the surgery as to how hormones will be replaced if necessary after surgical menopause rather than delayed or misdiagnosis.